We're happy to have you here. Yeah, welcome to Beijing.
Thank you.
Welcome to CMIT Congress.
Thank you very much.
Yeah, thank you. And we have just have the ESC Congress, and we have a lot of many good trials released. And do you have some recommend to us? Can you give some recommend some new trials?
So we have had a very good meeting with lots of important trials, very well published in very good journals like the New England Journal of Medicine or the Lancet. Maybe we can start by either REACT-5, which was a very explosive finding, I must say.
Yes. At first, maybe as an investigator, I think the ticagrelor will win, but it's to my surprise a lot. Why? Can you explain? I cannot. Why the result is so far as we expected?
Yes, I think it was also the hypothesis of the investigators that ticagrelor would win against prasugrel. There was no data before to support that. But at the end of this randomized study, 4,000 patients, prasugrel was significantly superior to ticagrelor. And it's not only a comparison of drugs, it's more than this. It's also a comparison of strategies. Yes. And that's where it may have played a big role. It's not just the drug is better than the other. It's also, for example, pre-treatment, which was mandatory for all patients with ticagrelor, with non-ST elevation ACS, when patients with prasugrel were not pre-treated, because there was a study that we performed, the ACO study, saying that pre-treatment is not good, and the study was performed with prasugrel, not with ticagrelor. So the patients were not treated at the same time. And another difference is also the fact that in high bleeding risk patients with prasugrel, the dose was adjusted down. It was not the case with ticagrelor. So altogether, because of pretreatment, because of dose adjustment, because of the drug, we have this finding, which is a difference between the strategies with prasugrel and the strategies with ticagrelor. And it probably tells us that we should probably be careful and individualize treatment in patients more than always say we give the same drug at the same dose to everybody.
Okay, do you think maybe we will change the guideline, the recommendation for the ticagrelor?
I think the guidelines may change to say we need to be careful with pretreatment, whatever the drug. Now it's only for prasugrel. I think the new guidelines should say pretreatment in general is not good in non-ST elevation ACS. And maybe there will be a mention of this head-to-head comparison. I'm not sure it will impact a lot the guidelines, because both drugs have a class 1 indication. Yes. So you cannot change it really.
Yes, but we have the priority recommendation for the ticagrelor for the ACS patient, I think. In China, we don't have prasugrel.
Yes.
So, after this trial, maybe, it's a really big news. At first, we don't have it in the market. Maybe right now, we need to consider that.
Yes, but the message, ticagrelor is a fantastic drug, and it's a better drug than clopidogrel for ACS. It's a class 1 recommendation. This is not going to change. But you may think of, when you use ticagrelor, be careful, especially in non-ST elevation ACS patients, and wait for the coronary angiogram before starting the drug, because this is where we have issues with pretreatment. There is an excess of bleeding complications. There is maybe a loss of efficacy in these patients. So this is the kind of message. We need to adapt what we do with ticagrelor and not think that this is the same drug, same dose for everybody as we have done in the past.
Okay, but for non-ST elevated ACS, maybe we don't have the loading, the pretreatment of the P2Y12 inhibitors.
Yes.
So maybe this message not very suited for our clinical practice, maybe.
Yes, you can adapt that to your practice and say, be careful, the final diagnosis of non-ST elevation ACS is made in the cath lab after the coronary angiogram.
So maybe some patients with very high ischemic risk, we can use that. Yeah. Like the ISA React 5, they will give me a better outcome. So yeah, it's nice. It's a nice trial. So maybe not only that, we have other trials for the ticagrelor, the CMIT. Yes, do you think? I think it's a little bit familiar with global leader. It's another kind of trial mentioned about the monotherapy of the ticagrelor. Yes. It's another. They give us more information about the stable angina, stable coronary artery disease for this kind of patient with diabetes. After the new guideline, I think it's like the same. It's for CMIT, we have enrolled patient with a stable CAD patient with diabetes, and in the Praxis trial, we have the ACS patient after 1 year. It's a stable ACS patient. It's in the new guidelines, the same patient. Yeah. It's the same. It's CCS patient. But they have a different study design and with a different result.
The new guidelines say that 1 year after your ACS, you have become a stable patient, and secondary prevention in these patients usually is one single agent, which is most of the time aspirin. And in TEMIS, in diabetic patients with stable coronary disease, they looked at combining aspirin with ticagrelor versus aspirin alone in 20,000 patients. So it's a big study. It was a superiority study, and the study is positive. So this association in stable patients was able to reduce death and myocardial infarction, and this is clearly very important. There is a price to pay, which is always the same, which is an excess of bleeding complications. So we need to be careful and select the patients, probably. The reduction of ischemic events is 10%. But if you look at patients with a prior history of PCI, which is a specific group in TEMIS, you have a larger difference. It's almost a 20% reduction of the primary endpoint, and the risk of bleeding is the same. But it's a group of patients, diabetics, a prior history of PCI, maybe 1, 2, 3 years before, they have a benefit of adding ticagrelor to aspirin. So I think the message is important, will be used in the future. We will select the patients. It's not for everybody, but we have another study saying that ticagrelor may be used for a longer period of time than 1 year after ACS and stenting.
So maybe the prolonged use of that, maybe we can consider for some specific population, like the patient with diabetes, with prior myocardial infarction, or after revascularization. This kind of patient have a higher risk of ischemic events. But if they have they don't have a high risk of bleeding, so we can prolong the depth. And if they have a high risk of bleeding, we can change to ticagrelor normal therapy. Maybe we can downgrade the dose to 30 milligram, like Praxis trial.
Yes, I think this is exactly what you say. We need to select the patients. Diabetes is one item, prior revascularization is another one. High ischemic risk in general with diffuse disease, maybe you may be worried, and you think DAPT with ticagrelor would be better. Now we have data to support it. And at least this study, which is 20,000 patients, is positive because global leaders, only with ticagrelor and no aspirin, was neutral. So we see that to get the benefit, we probably need 2 agents and not 1.
For me, I think it's another message for us because We used to have aspirin like a monotherapy after 1 year. And right now we can change to other P2Y12 inhibitors. Do you think if maybe we can have another drugs like ticagrelor as a monotherapy for the primary prevention of the cardiology, for the like a drug for the primary prevention?
In primary prevention, it's difficult because we have no study.
Yes.
And this is not exactly primary prevention.
It's a secondary.
It's secondary prevention. Sometimes.
But they have better outcome for this specific population.
Yes. So patients, when they have a sign of coronary disease, sometimes it's a stenosis, no event, no prior MI, no prior stroke. So it's a kind of secondary prevention because you have demonstrated on the CT scan, for example, that you have a stenosis. This treatment is useful in diabetic patients.
Okay, so maybe you can just choose some specific patient for this drug.
Yeah.
Okay, but how long do you think you can use this?
You know, the study is limited. It's 3 years globally. But
for 5 years, I think, the maximum for 5 years.
Yeah, it's up to 5 years.
Yes, up to 5 years.
Up to 5 years. On average, it's shorter. But when you say 5 years or 3 years, it means that you have a treatment for life. If the patient does not bleed, you can continue as long as you wish.
As long as I wish.
It's just like with the statins. You know, we have studies which are 3, 4, 5 years, but you continue statins lifelong.
So you think we have the evidence of 5 years, but we can use it for lifelong?
For a longer period of time.
Because my patient asked me this question. Because for him, I think it's very good for him, and I use it longer for more than 2 years, and after that he hesitated. He asked me if I need to downgrade to clopidogrel or something else. It's common to use clopidogrel for a long time, but it's not used to this one.
We don't have a similar study in diabetic patients with aspirin and clopidogrel. We don't have this study. We have a study, Charisma, in primary and secondary prevention. It did not work in primary prevention, but it worked in secondary prevention. So yes, we have several options now.
If we use it for a longer time, do you think we need to add PPI, for example, to prevent the, for gastrointestinal bleeding?
I think it's wise to use PPI in these patients when you use aspirin, which is toxic for the GI tract. Yes, it would make sense to use PPI widely.
For ticagrelor, maybe it's more safe for the GI bleeding, maybe.
Yes.
The long time to use PPI is not good right now. We have some more result out of that.
Yes, I agree. There are also side effects of long-term use of PPIs. Over a 3-year period, probably not, or 5 years. Yeah, it's a question of risk-benefit.
So I think over 5 years, maybe I can use it 2 years, 3 years, but over 5 years, I don't want to prescribe that. Maybe just use a temporary for months, and after that, maybe I will sense that. Okay, so maybe you can talk about another trial, popular genetics. As I think for this trial, I also feel surprised because it's just like this escalation of the P2Y12 inhibitor for some patients with, although they have the genetic testing, but it's also for the patient with high platelet reactivity for this patient. I know we have the tropical ACS, it's a negative result, but why this one have a positive result?
It's I think the first large study looking at clinical outcomes with genetic testing, and it has been a question around for years. We have other studies that will be published soon, like Taylor PCI, but this one is interesting because it's very simple. They use a Spartan system with a buccal swap, and they looked at these patients with CYP2C19 star 2 or 3, so the patients with a loss of function, and these patients are, let's say, resistant to clopidogrel. And for these patients, they use ticagrelor or prasugrel, and the others, they use clopidogrel. And the control arm was ticagrelor and prasugrel in everybody. And they found out that the primary endpoint, which is the need clinical benefit, so a combination of ischemic and bleeding events, was not different between the two arms. So the new strategy using genetic testing was non-inferior to a strategy where you don't do it, but you use ticagrelor and prasugrel in everybody. So you may find this result disappointing, but on the other hand, you may say, you know, I can treat these patients most of the time with clopidogrel, which is less expensive than ticagrelor and prasugrel, but you have to pay for the genetic test.
Yeah, it's very expensive here in your country.
Yes, but you pay once.
Yes, once in lifetime.
Yeah, once in lifetime. The treatment is going to be at least for a year in this type of ACS patients. And the other finding is that most of the benefit is observed on safety, of course, because you have one group with full ticagrelor or prasugrel, all the patients, and the others have clopidogrel, so less bleedings. But here I am personally a little bit disappointed because it's only minor bleeding which is impacted and not the major bleeding. So my take on this trial is that if you do not have a good economic reason to do it, it's going to be difficult to adopt because you have no difference on the primary endpoint, you have only a difference on minor bleeding, and it's a little more complex as a strategy. And if you can pay for ticagrelor, you know, it's probably easier to use ticagrelor for a year after the ACS.
The safety point is driven by the minor bleeding. So is that matter for the, what do you think? Because for the guideline, if they have that minor bleeding, for my patients, I just say keep going, do not mention that it's just minor bleeding. It doesn't matter. So does that have a clinical significance for this kind of endpoint?
You know, minor and major bleeding, it's not exactly the same. Major bleeding is a real event. Minor bleeding usually is not. Some would say minor bleeding is not trivial because they may expose to further major bleeding. But in this trial, this is not what we see. You know, it's a balance. If you want to do it, I think we have data now to do it. We will see what the other trial shows. It's interesting. It's the first real positive trial for genetics.
Yes, it's the first one. But everybody feels, you know, at first when we see the result, we feel very good because all the company want to do this.
Yeah.
But you know, when we see the it's just driven by the minor bleeding, it's no, maybe we can think it's more conservative. Okay, so let's move to the other trial for the complete trial. For this one, it's also very good trial because we have a strategy for the STEMI patient for if we need to do the complete revascularization or just do corporate lesion only revascularization for this patient. And for this trial, I think for the complete revascularization group, they do the procedure maybe simultaneously on the primary PCI or later within 2 weeks. I remember in the 2 weeks after the initial procedure. Yes. So is that all? Do you think? What would you think for this kind of strategy?
So the complete trial is the first large trial looking at the question of total revascularization or only the culprit lesion revascularization in patients with STEMIs. We have had several smaller trials, a couple of hundreds of patients, and now we have a study with 4,000 patients. So it's a large trial, much larger than the others. And it's the same hypothesis. What they found is that complete revascularization, all the arteries, immediately or a few days later.
2 weeks later.
Yeah, within 2 weeks. A few days later, within 2 weeks, is superior to only providing PCI in one artery, which is a culprit artery. And in this group of patients, control group, where there was only a PCI performed on the culprit artery, they never perform revascularization of the other arteries, even if there was demonstrated ischemia on the other arteries. And this is where I do not agree, because this control arm is too conservative. Nobody would do that. At least in my institution, my country, we would be very worried, even if we are very conservative, to leave a patient with ischemia demonstrated on, for example, a stress echo in another artery and say, we are leaving the artery with a stenosis, or to leave a very tight stenosis on another artery when we know that FFR is going to be significant, and so on and so on. So the control arm is a group of patients who have been undertreated, and it explains a big difference which has been observed in this trial, which is a positive trial. But again, what we do is not in the control arm and is not also on the tested arm.
Yes,
so
it's not.
We are in between.
We are in between. So that after this trial released, I feel confused. What should we do next? For this kind of patient, for multivessel patients, maybe we can do, if the patient is stable, maybe we can do the complete revascularization simultaneously on the primary PCI. But if it's not stable, maybe we will do it later. If they have ischemia, angina, we will do it later. But we don't have, like you said, it's not the same like the two arms.
Yes.
But if the patient is stable, maybe we can leave it later.
Yes, I think the take on this study, just like the others, is that yes, when you have a multi-vessel patient with STEMI and when you perform primary PCI on one artery, if you need to revascularize other vessels, you can do it, and you can do it in the same hospitalization or a few days later, but you need to do it.
But it's the same information like other trials.
Yes.
But what is the new one?
The most important point is that this study is adequately powered. There is a sufficient number of patients to conclude. The other studies were too small, and it's good to have this information because, for example, in STEMI patients with cardiogenic shock, we have had also large studies, a culprit shock, with the opposite conclusion. We should not revascularize the other arteries. So if you have no shock, yes, you can do it. If you have
shock, you cannot do it.
Be careful and don't do it.
So it's the same. You think it's the same information like other trials?
Like the culprit study, for example.
So maybe this, but it's a very big trial with a lot data, for this. I think the positive result is part driven by the revascularization, the ischemic initiate revascularization in the control arm. But for this kind of patient, like you said, it's not. They do too conservative strategy in that control arm. They don't. This kind of patients, they will have this kind of events because we don't trace the vessel.
Yeah.
So the results make us make a little bit confused. So maybe we don't need to that. Maybe if we don't have that endpoint, maybe it's better for the revascularization to move out that endpoint to see just a death or MI. Maybe it's better to see the...
I think the message is we need to revascularize all the vessels when we can do it, and not leave behind tight stenosis. The time of revascularization is not important because in this study they looked at the effect of time immediately or a few days later, and it had no impact. So, you know, it's not going to change my practice very much because we already tend to do that. But for some centers, maybe it may change in a way they need to be more aggressive in terms of revascularization of these patients.
Maybe we just focus on the endpoint of death, not to see the MI or the revascularization. We just focus on the endpoint of death. If they can reduce the mortality, maybe it's more better, but if it cannot...
Yes, but the trial is too small to look at mortality only, so...
So we cannot say that, give a firm conclusion. Okay, so we move to the other trial of DAPA-HF. Yeah. So this drug is for diabetes, but released on the ESC Congress. So for this drug, I think maybe it will no longer be a diabetic drug anymore. It will be a cardiovascular drug. You know.
Yes, we know that this class of drugs, glyphosins, are very effective in diabetic patients. We have had very good data in diabetic patients showing reduction of ischemic events, reduction of deaths, and also reduction of hospitalizations for heart failure. So the next question was, if we take this drug and in a heart failure patient, is it going to work independently of diabetes? And this is what was done in a DAPA heart failure study. They tested the drug in heart failure patients, not looking at diabetes in particular. And what they found is a striking result, because they have reduction of the primary endpoint, which is very impressive, and the primary endpoint is death or heart failure, motivating an hospitalization, and they have also shown a reduction of mortality, which is significant, 18% reduction of mortality in this patient. So yes, this drug works in heart failure patients, and it works as well in those who had diabetes as in those who had no diabetes.
Yes, so I think it's another drug. It's a cardiovascular drug.
Yeah.
Yes?
Yes, it's a drug for heart failure now, not only for diabetes.
So I can prescribe that for heart failure patients.
Yes.
It's good.
Yeah.
No matter if they have diabetes.
No.
Okay, good. I will try it. I think it's a very impressive result for this trial.
Yes.
So, but I'm not very familiar with the drug. I have never used it.
Yeah.
Okay, so I can try it for heart failure patients right now. Okay, so so at the end, maybe we can talk about the guideline, the chronic coronary syndrome guideline. It's very impressive of this one. We have a new definition, I think.
Yes, they have changed the title. It's not stable angina anymore. It's chronic coronary syndromes. I think it's more marketing than anything new really with the disease. They have shown the different situations corresponding to these stable patients. And what is new, I think, is that they have upgraded secondary prevention. We had a 2B recommendation for example, ticagrelor in addition to aspirin in secondary prevention of these patients according to the Pegasus study. Now they have given a 2A recommendation, but they say it could be ticagrelor, but it could be also another drug, maybe clopidogrel, maybe prasugrel, maybe rivaroxaban 2.5 milligrams, because we have very good data also with rivaroxaban in the COMPASS study. So they do not grade these drugs, but they offer the possibility to use them.
Yes, it's very interesting for me. I think if the patient with chronic is in the stable stage for this kind of patient, we can prolong that, or we can use anticoagulants.
Yes.
So it's which do you prefer for these two different? I don't know, because it's different drugs. It's antiplatelet drugs and anticoagulants.
Yes.
But why all of them can do something to give some impact for the patient?
Yes, but in the COMPASS trial, rivaroxaban 2.5 milligrams BID, which is a small dose, a low dose of rivaroxaban associated with aspirin, has a beautiful effect on PAD, peripheral arterial disease, and in polyvascular patients in general, and in patients with diabetes or renal dysfunction, for example. So I would suggest to think of rivaroxaban in polyvascular patients, for example. Ticagrelor with aspirin, I think is probably better adapted to pure high-risk coronary patients with multiple stenting, without PAD, without heart failure, without diabetes maybe. You know, it's a discussion. I think both drugs are possible, and we need to choose the one that we want to use.
Oh, it's just the different type of patient. We have different type of drugs.
Yeah.
For the patient with stent, maybe we can use more pure coronary artery disease. We use anti-platelet drugs. And if they have PAD with other disease in the vessels, in the whole body, maybe we can use anticoagulants.
Absolutely. If you want to continue your DAPT with ticagrelor, it's easy, it's possible. We have Pegasus, we have Themis. It's good to do it. If you have a PAD patient, you have also rivaroxaban, which is a good drug, and which had an impact on mortality, as you remember.
Okay, but if we have a patient with stenting and maybe atrial fibrillation, and we want to prevent stroke, not only for anti-platelet, we want to also anticoagulant. Which one is better? Like I-5?
No, it's a different question, because in this case, you need anticoagulation. You need a different dose, a high dose. So it would be a 15 milligram dose for rivaroxaban, maybe even a 20, some people say. And you would have certainly aspirin combined with rivaroxaban and clopidogrel during the hospital phase. But as soon as the patient leaves the hospital, you can remove aspirin and continue with clopidogrel and rivaroxaban full dose. We have now several studies suggesting that dual therapy is enough.
It's like the patient with an indication of anticoagulant. In our daily practice, we have a lot of patients with left ventricular thrombus after ACS maybe. We don't know which kind of antithrombotic agent we need to use and how long.
We have observational data saying that you need to give anticoagulation to these patients. It's going to work in more than 50% of patients. The thrombus will disappear. And you can use NOACs, because now we have data with NOACs. The problem is that usually you have dual antiplatelet therapy, and I would be very careful in using one antiplatelet agent, maybe 1 month after the ACS, if it is an ACS. Keep the triple treatment for 1 month, but at 1 month remove. Yes, because you have full anticoagulation now for your thrombus. So full anticoagulation, maybe plus clopidogrel for the following months. If you are very worried, maybe triple therapy, but the risk of bleeding would be very high.
We just use maybe triple antithrombotic therapy for three months.
That's okay also.
And after that, we want to sensate maybe one aspirin,
Yeah.
leave clopidogrel and NOAC, and then thereafter.
I think this is fine. You can do that. 3 months is acceptable. I say 1 month, but nobody knows really.
Yes, nobody knows that because when we sensate at 1 month and the thrombus come back and we add it and we think it's 3 months is better.
Okay, good for you.
Okay, so maybe you can talk about the optimal phrase to change or to make a new decision of the antithrombotic therapy. Maybe after, for your opinion, we have a guide on the new guideline. Maybe at the first we need to make a decision. Wait at the point of revascularization, we need to make a decision which kind of depth we want to use, and after 3 months we can change, and after the time point of each part, which do you think?
I think you can use this second agent at any time point when you face a chronic coronary syndrome patient. If the patient comes to your consultation on aspirin and he has had an acute MI 5 years before, you may think if he is a high risk to give another agent for the prevention of another MI or a stroke, and you have to choose what it should be. So it's not only for the recent cases, it's also for the old cases. You may tell the patients, now we have shown that you may be better protected with one more agent, which could be ticagrelor or which could be rivaroxaban, for example.
Okay, maybe I think maybe next year we will release the new guideline of the non-ST elevated ACS patient. Yes.
Next year.
Next year.
In 2020.
Okay, in 2020 we will have a new guideline.
Yes.
Okay. So right now we have the recommendation for the chronic coronary artery disease patient, and we can have choice for the antiplatelet agent or anticoagulant. And do you think is there any room for the anticoagulant for the ACS patient after the procedure? Is there a room for?
We have had a study in the past, which was the ATLAS study, with 2.5 milligrams with dual antiplatelet therapy. And it was very effective. We had a reduction of mortality. We had a reduction of stent thrombosis. So it was very effective and it could be used. Now we had also an excess of bleeding complications. So I would be careful if it's not necessary to use this systematically in this type of patients. I would keep this drug mostly for secondary prevention, distant from the ACS phase.
You mean just in the acute phase or?
Acute phase, I would not use it because the risk of bleeding is high. But after the acute phase, after the first 6 months, for example, yes, it's a possibility.
For non-ST elevated ACS patients?
Yes, non-ST or even for STEMIs.
Or even for STEMI. But
Yeah.
For your editorial comment on the JAC, you make a picture for all the agents, for anticoagulant agent.
Yeah.
We can use it at the procedure, during the procedure, and 1 year after we have COMPASS trial, we have superiority of that. But we have a blank.
Yeah, black box, yes. This is where we need more data. We don't know exactly what we should do, between the acute phase and the secondary prevention. Here there is a question mark on anticoagulation, just like we have a question mark on anticoagulation immediately after coronary reperfusion. You are doing the right trial to answer this question. It's a black box. We will have more data with this trial to know if we need to prolong anticoagulation or not, and for how long, nobody knows.
If we can use it, maybe there a little room for anticoagulant within 1 year after ACS patient?
Maybe, and again, it was tested in the ATLAS study during the first year, but we have no approval to do it. There is no approval. In my country, we don't have it. In some countries, it's possible. You know, it's a balance. If you do it, you are going to increase the bleeding risk, but you will reduce mortality and stent thrombosis. So you need to be very selective for the patients, I think.
So maybe just within the hospitalization, use that. It's okay. Yeah. After that, maybe it's no.
And again, it was tested mostly with clopidogrel, not with ticagrelor, for example. So I would not do aspirin, ticagrelor, and rivaroxaban. It's too much.
Okay. So thank you very much. It's the time.